Hi, I'm Iwei and I'll be discussing Miss CK, a 44-year-old left-hand dominant lady presenting with pins and needles and numbness in her left thumb, index, and middle finger. I'd like to know if she has any other symptoms for current medical complaint, like weakness in the hand or wrist and pain. I'd like to know if anything happened to trigger the numbness. Does she have any current or past medical history? I'm looking out for arthritis, diabetes, past hand trauma. Is she on any medication? What does her 24-hour behavior look like, including her sleep position and if she sleeps on her left arm? Does she have any other aggravating activities, perhaps putting her hand in a certain position or typing for long hours? Any easing factors? If she has her night splint with her, I'd like to see how the splint looks like and how she wears it. And does she do anything else to manage the numbness? I'd like to know her pre injury and current functional capacity. How long does she need to drive for? How long can she currently drive before the onset of numbness? What does she do at her catering business? Does she work with computers or cook? I'd like to know her social history as well. Does she live alone or with family? Any activities or hobbies, and if they are affected by the numbness? I'll ask if she has any goals or activities she'd like to return to, and throughout the conversation, I'll be looking out for yellow flags such as kinesiophobia, catastrophizing, anxiety, and depression. Based on the subjective, my differential diagnoses are carpal tunnel syndrome, compression of the median nerve between the heads of pronator teres, and C6 radiculopathy. I'll observe the posture of her hand and the condition of the skin, if it's smooth and shiny, any discoloration or erythema, any scar or wound along the arm and the hand, any swelling in the wrist and finger joints and tendons, any muscle wasting, particularly in the thenar eminence. I'll palpate for tenderness and swelling along the median nerve to the elbow. CK will perform neck active range of motion to see if the neck movements trigger the numbness or pins and needles. I'll measure her wrist and thumb range of motion with a small goniometer. If she's not too irritable, I'll test her grip strength and pinch strength for lateral, 3-point, and 2-point pinches. I'll also perform muscle strength testing for intrinsic thumb flexor, opponents, and flexor digitorum superficialis, and also testing her dexterity with a 9-hole pet test. I'll perform Tinel's and Phelan's test for the wrist, as well as a Tinel's test for the pronator teres head, also a neurological test for sensation, muscle strength, and reflex to rule out radiculopathy of the upper limb. Further investigation of nerve conduction studies, ultrasound, or MRI can be considered if the clinical examination is unclear. If there are marked or deteriorating neurological symptoms, presence of red flags, or conservative treatment was not effective after implementing. I'll refer to the hand surgeon if there is an obvious wasting of her thenar eminence, and if she reports constant numbness throughout the day and conservative treatment was not effective after 6 weeks. I can also refer to the dietitian for weight loss if the patient is overweight. With a assessment, I found that she has carpal tunnel syndrome with no muscle weakness. I'll explain to CK that 1, she most likely has carpal tunnel syndrome with a hand model as an aid, and 2, I'll explain to her the reason for her numbness at night and during gripping, and 3, most people will recover and that she can return to her activities with management. She should continue doing the AD activities of daily living that she can do with modification to the aggravating activities. With discussion, we will work out if she can be driven to work or work from home for the first 3 weeks, giving her nerve a chance to heal. She can hold her phone in the right hand to use it. CK owns her catering business, so I check with her hand posture at a computer and advise on the ergonomics, especially to keep her wrist and forearms relaxed and rested on the surface to remove excess flexion or extension. She can take photos of her working area for the next session so we can further discuss how to improve the setup. Her current night splint was ineffective, so I will make a new thermoplastic splint for the left wrist to maintain a neutral wrist to be worn at night and clearing the MCP joints. The splint can be worn for 3 weeks, and then she will wean off using kinesiotaping for proprioceptive reminder to maintain good wrist posture after 3 weeks. I'll prescribe median nerve gliding exercises to CK for 10 reps, 3 sets daily, and assess her symptoms during the exercise. She can do this before going to work, during breaks, and before going to bed. And she shouldn't feel pain or increased numbness during the exercise. She can progress by increasing the elbow range of motion and by adding contralateral head side flexion. I'll have a follow-up session a week later and check in with CK for the efficacy of the night splint in regard to her sleep, and if the exercises are manageable when she does it on her own, and if they need to be progressed. I'll also check to see if the signs and symptoms have progressed or regressed. If there is a sudden deterioration, I'll refer to the hand surgeon for review. I'll see her every 2 weeks after that. The return to work or function can begin with reduced duration of driving and using her phone with her left hand, like driving for 10 minutes to the grocer, using her phone for 10 minutes and then switching hands, or typing for 20 minutes and then taking a break before the symptoms set in. To progress, the duration can be extended and she can perform increasingly heavy-duty or complex tasks while monitoring for symptoms with her left hand until she reaches her usual amount of activity. And that is my management for CK. Thank you.